To today's webinar. My name is Carol Barry, and I will be introducing today's speakers after I go through a few housekeeping items. There is a Q&A session at the end of today's presentation, which is improving palliative care in long-term care homes using participatory action research. Please submit your questions during the presentation, and we'll try to answer as many as possible. We will have Perry Kim, our research manager, host our Q&A today, and we will also provide a contact email for questions that we can't cover today. As the presenter said, if we couldn't get to all the questions, they'd be happy to respond to other questions. Just a reminder that we would love to hear from you in terms of feedback on the presenters or on the presentation so we can continue to improve our webinars. And the webinar slides and the video will be available within the next 24 to 48 hours, and the URL is on your screen now. For our upcoming webinars, which I'm hoping that everyone will be able to join us, they are usually on Wednesdays and they're at noon. So the next one is October 11th, and it is Teleprom, a study evaluating access and care delivery of telehealth services among community-based seniors. And that's with Cheryl Forchuk from Lawson Health Research Institute. And on the Wednesday, October 25th, we'll have Heather Keller with More to Eat Nutrition Care Pathways and Optimized Protein Supplementation for Malnutrition Patients Living with Frailty. And that's a CFN funded strategic impact grant. We also have one on Wednesday, November 27th with Richard Sawatsky and Marian Krawczyk. They're going to be introducing the electronic quality of life assessment in hospital palliative care. And right now we still have a current competition in process. It's our Catalyst grant. It is due on October 6th of this year by 5 p.m. And it is with both New Brunswick Health Research Foundation and CIHR to address polypharmacy and related medication issues in older adults living with frailty. As you can see from our screen, you'll see the website for more details. So I'd like to go ahead today and introduce our presenters. The first presenter is Cheryl Castellanen, and she's the Associate Professor in the School of Nursing at McMaster University. She's an Associate Member of the Department of Family Medicine at McMaster. Then we have Tamara Sussman, who's an Associate Professor in the School of Social Work at McGill University. She obtained her PhD in Social Work at the University of Toronto, followed by a postdoc fellowship at Murray Alzheimer's Research and Education Program at the University of Waterloo. And our last presenter, there's three of them presenting in all three different locations today, is Pamela Durapo. She's a second-year doctoral nursing student at McMaster University, and she's employed at Hamilton Health Sciences Corporation in the Neurotrauma Intensive Care Unit for the past 13 years. So please go ahead with your presentation.
Great. I've just lost the slides now, Carol. I'm wondering if they're going to be back up. Am I the only one who doesn't see them?
No, it's Tamara. I lost them too.
They were there and then they disappeared.
Yeah, I don't see them either.
So we will put them up and you can see them as you go ahead. Normally we would, you would be able to accept them as the presenter. So maybe something has gone wrong on our side, so we will put them up now.
Okay, great.
See those? Okay.
That's great, thank you. So first of all, I have to say, warn people, if there's anything wrong that will happen to technology, it'll be when I'm presenting. I seem to jinx everything when it comes to technology. So hopefully we can get through this relatively easily. I'm just delighted to be able to talk about our Strengthening a Palliative Approach in Long-Term Care project, along with my co-lead, Dr. Tamara Sussman and Pamela from McMaster. We've been working on this project for the last almost 3 years now, and it's been growing every day as we progress along. First, I'd like to acknowledge the funding and the support that we've received from the Canadian Frailty Network, as well as Extendicare Canada and Shalom Village. So today we have about 35 minutes to talk about our initial findings with our SPA project. So we'll give you kind of an overview of the program and how it was developed, talk a little bit about some of the research methods that we used in our study, and then go on to talk about the findings around our surveys, our focus groups, and our family care conferences, and finally our illness trajectory pamphlets, and then give you a quick snapshot of our next steps that was just recently funded, again through CFN, for an advanced care planning project that will extend our SPA work. And we're aiming to have at least 20 minutes, 25 minutes for questions and discussion after our presentation. But as Carol mentioned, feel free, we will be giving you emails of our project coordinator, so feel free to contact us after the presentation if you have any questions or feedback. Okay, it looks like I can't do the slides, so I'll have to rely on you there to do that. So we'll give you an overview of our SPA project, and we'll start with some basic background, really about long-term care, the state of long-term care as it is now, and some of the statistics that we know about the current status of residents in long-term care. For some of you, this may be old news, but for others, it may be new. And hopefully it's of interest to everyone on the webinar today. So as we're seeing, certainly residents are coming into long-term care a lot more frailer. They're having a lot more complexity in their care. The old days of having residents, drive to long-term care and admit themselves into their room are long gone. We're now seeing residents coming with 3-5 comorbidities on, anywhere from some of them as high as 20 medications on a daily basis. So it's a very complex population with high needs and high care. And unfortunately, we're seeing many of them are dying a lot sooner. We're almost at about 27% we're seeing residents die every year, so almost a third, and that rate is just going to go up as we're seeing more and more frail residents entering long-term care. And you'd think with that high rates of resident deaths, we would be really good at managing palliative care and end-of-life care for this population. But unfortunately, we're still seeing lots of gaps in care and kind of unnecessary suffering for both residents and their family members. So that's really the goal of this project, is how can we improve the palliative and end-of-life care for this population. It's particularly difficult and challenging for people who have dementia. They have challenges with symptom management. We know that pain isn't managed as well for people who have dementia. Certainly we're seeing a lot of gaps and we're lacking discussions and advanced care planning work before we kind of hit end of life, and that leaves, without those earlier discussions, we're finding residents and families are in crisis mode, having to make these decisions at the end of their life. And we're also seeing a lot of inappropriate hospitalizations, which are quite troubling for both the residents and families and the staff caring for them, when most of them would prefer to die in their long-term care as opposed to dying in the hospital. So all of this really speaks to a need for a palliative approach in long-term care. So this is something that Tamara and I are really trying to build. Is right at admission, start thinking ahead and working with people so that we're not leaving all of these conversations and decisions at the very end of life when people really aren't prepared to make some of these decisions. And we're also wanting to focus on symptom management across the whole trajectory, not just when someone is dying, we start thinking, now we need to start thinking about pain management and managing these symptoms. But if they're having pain, even when they first get admitted to long-term care, it just makes sense we start dealing with pain management when it occurs, not just at end of life. And we really want to talk about care preferences beforehand, and not just, again, when they're nearing end of life. So within a more proactive approach, getting families and residents prepared for discussions, giving them the knowledge and the tools that they need in order to make informed decisions at the end of life. So we were quite fortunate, Tamara and I, to receive some funding from CFN as a strategic impact grant back in 2014. And that essentially launched our SPA long-term care program of research. And we have the program itself really is a multi-component program. Evidence-based, we looked at what was kind of the key components that we thought needed to be in a palliative program within long-term care home. So this whole program is based on participatory action research, which is in some ways, you know, it has a strong quality improvement focus. So it's the goal isn't just about doing research and getting data and analyzing data, but ultimately the goal is to really make a change in practice and at the system level as well. So it's very iterative, so we have cycles of collecting data, analyzing it, trying to make sense of it, and then taking it back and working with staff and our advisory board to try to make some change within the system and at the practice level to improve practice. So next slide, please. That's great, thank you. PAR research, it's much simpler to call it PAR rather than participatory action research. It really is focused on empowering staff, empowering families and residents. It's research that's conducted at the ground level. And the focus really is around supporting the development of care practices that clinicians and knowledge users view as important and feasible. So we may have our own ideas of what we would like to see changed in practice, but if the people who are going to be making the changes don't see that as a priority or feasible, then quite likely those changes won't happen. So everything we do, for the most part, involves discussions and collaborations with our long-term care sites, frontline staff, and we gathering information from our advisory board as well. So it's very much a collaborative learning exercise based on teamwork. The researchers are very much, we try to position ourselves as team members within the long-term care sites. It's always nice when they tell you they keep forgetting that you're a researcher, that they think you're just one of the team. That's one of the best compliments I think we can get as researchers when they see us as just being part of the team. So ultimately, PAR research, we really want to see sustainable change. So all of the work we're doing and the data that we're collecting, we want to use that to really create some change that frontline staff see as feasible and as helpful in their practices. So our research design, we're not going to go in too much depth about our research design, but if anyone's interested, some keen researchers out there, send us an email and we're happy to give you some more details about our research design and methods. We opted to use a mixed methods approach just because we had so many different types of research questions. There wasn't one method that really suited all of our questions. So in this way, we're able to collect focus group data, survey data, and chart data to really get a good handle on what we needed to find out about and how we wanted to evaluate some of our activities. We chose a case study design partly because we wanted to look at what are the different types of situations that exist in Canada, because we know there's lots of variability around long-term care homes. So there's profit, not-for-profit. We have some rural, urban. Administrative turnover is one of the key indicators to really show that interventions are successful, and also facility size. So that can dictate kind of how some of these program components will be implemented. So we strategically chose 4 different homes as our cases to do this study. So this is kind of a busy slide, but it shows the core components of our SPA program. You can see on the bottom, it's consistent with the PAR approach, where the research team, is really there to help support the long-term care home. We're not at the top of the slides. We're at the bottom, really trying to support the long-term care home. Along with the advisory board, we have about, I think we're over 30 partners right now. So we have families and residents, clinicians, professional organizations at the local, provincial, and national levels to help us with this project. And we try to draw whatever resources we can from the community. So for this particular project in Ontario, we have palliative care consultants that work in the community, and part of their mandate is to help support long-term care homes. So this project really acted as a catalyst. So how could we leverage that support that exists within the community to help support the long-term care homes implement this program? So the first step that one of the main components really of SPA is to develop a palliative care champion team. And that was something we did initially with each of our sites. Who were the core people who are interested in palliative care and seen as the opinion leaders in the site? We went on to hold comfort care rounds, really as kind of an informal training opportunity for staff. And this is where we leveraged the palliative care consultants in the community to come in and host these comfort care rounds. One of the initiatives that we tried was the palliative performance scale. And that's a scale that some people like, some people don't like. To be honest, it was the only tool that we could find at the time that we thought was feasible and useful for long-term care. So we used the palliative performance scale really as a trigger to recruit residents and families in order to hold a family care conference. And we'll talk a little bit more about that later in the presentation. And then, of course, offering some bereavement follow-up was very important and certainly expressed as a need within the long-term care homes. So now we'll just go on to talk a little bit about the findings. I'm going to talk about the staff survey findings. Tomorrow we'll move on to talk about the focus groups, and then Pam will share some of her work she did for the family care conferences. So the staff survey we did very early on. We really wanted to get a sense of what kind of where the staff were in terms of their comfort level and knowledge around providing palliative care and end-of-life care. So we found a tool. Tamara actually found the tool. We liked it because it's an interprofessional tool that we could use for all staff. There's some tools just for nurses, but we wanted one that we could look at across different disciplines. And there's 3 main scales within this tool: families and patient-centered communication, cultural and ethical values, and then effective care delivery. So that was all housed within that survey. And we had a second survey we wanted to look at intensity of interprofessional collaboration. And it was just a short, I think it's like a 10-item scale that looked at how staff viewed interprofessional collaboration around care sharing and coordination. So we ended up with a modest response rate of 45%. We started out administering around 600 and just under 700 surveys. We worked very hard and probably drove all the staff crazy trying to get them to complete the survey. We ended up with 317 completed and a fairly good representation across discipline groups. I think we had, so the registered staff would be nurses, physicians, pharmacists, and social workers. So some of the key findings, just quickly, we found that not surprisingly, personal support workers or care aides and support staff appeared to have higher needs for education around providing palliative care and end-of-life care. But we found, which was a bit surprising, we weren't expecting, so support staff had significantly higher needs related to their comfort level with palliative care and their sense of integration on the interdisciplinary team. So this really, alerted us to the fact that we need to make sure we include support staff, so that being dietitians, rec staff, maintenance staff, all of those people that we often, forget about when looking at palliative care education, but really are just as integral on the team and often faced, with questions and comments from families and residents. So that was our main learning from the survey, and certainly it's something that we're working, trying to remember as we build in new interventions and education to make sure we include the support staff and provide opportunities for specific learning for them. Okay, well, I think the next slide, is our publication on that staff survey. So it's an open access publication, so you can just click on that link if you want to get to look at that publication a little bit more. Or if you want to give us an email and find out any specifics around that particular study, we're happy to do that. For now, I think I'll pass it over to Tamara to speak about the focus group findings.
Great, thanks, Sharon. So as Sharon mentioned, this was a PAR study, and what we have come to do often when we start out with these kinds of studies is do some pre-implementation focus groups with the purpose of first, kind of understanding the context in which we're working. What is palliative care? What are people understanding it to be? How is it being experienced currently? But it's also about getting people's perspectives on our proposed interventions and kind of engaging knowledge users at the front end of the research. So I'm going to present some of the findings of, what the current practice was before we began. And a little later on talk to you about how we adapted things based on some of their feedback. So in total, we did, across the 4 sites we were implementing the intervention, 19 focus groups with 117 participants. So we got a lot of rich data, and you can see on this slide very well representative of the different stakeholder groups within long-term care: residents, family members, personal support workers, support staff, which meant people in dietary, recreation, and then regulated health, allied health professionals. The main findings from this group, most people, when we asked them what is palliative care, how is it practiced here, what came up was this notion of comfort. They really spoke about end-of-life comfort, that palliative care and long-term care meant trying to offer physical, emotional, social, and spiritual comfort to a dying resident and the family that was supporting them. But what was sort of poignant was that that notion of comfort only kind of got activated in the final days of a resident's life. So when someone was actually noted to be dying in 3 days to a week, everybody sort of switched gears and comfort became the focus. So what we found was that by focusing on very end of life and thinking about comfort in that way, there were a lot of missed opportunities for providing comfort at other stages that we know to be important in a palliative approach. So one was this notion of missing opportunities to talk to residents prior to their experiencing end of life around wishes and fears that they had. Some people refer to this as you know, largely defined advanced care planning. Recognizing that in the context of long-term care, people were observing other deaths, and because of that, they had made observations about that what they would and wouldn't want themselves. And because they didn't have the chance to talk about that with staff, if they saw something they wouldn't want, it kind of led them to question the long-term care home's capacity to provide end-of-life comfort to them. If they found stuff that they really liked, you know, they felt a little luckier. But, you know, this notion of talking in advance with residents about what they might find comforting was kind of a missed opportunity. Also, the people who were caring for the actively dying were comforted when they could provide good care. But if they couldn't provide good care from staff, this might mean because they were short-staffed and they couldn't be there for as much as they wanted. For other residents, it could mean because they didn't know someone was dying and they would have liked to have been involved. It could have real lingering effects on how they experienced and how they experienced the dying process and what it meant for their own care in long-term care. And finally, this notion of bereavement, honoring the death, was another thing that really kind of went unspoken. There were rituals in long-term care, but when an individual died, there was a lot of lack of processing of that individual death, which could be lingering for people. So, you know, the implication here was that the fact that comfort was a multidimensional concept was wonderful, but the fact that it became the focus largely in the final days meant we had a lot of missed opportunities, both at the front end in this sort of planning ahead and in the back end in the bereavement process for really all parties, the residents who were remaining, the family members, and staff. So I think the next slide is just the publication list that you can find some of the broader based findings from the focus groups, and I will now pass it on to Pam, who will talk about the family care conferences.
Thanks, Mara. So yes, I'm going to talk about family care conferences, which are one of the main elements of the SPA intervention. So, sorry, let me move my slides here. So family care conferences are structured family meetings, and the whole purpose is basically to bring together residents, family members, and staff to discuss current issues and make plans for the current status of the resident and identify things that they may want to occur during their end of life and for the family into bereavement. So family care conferences were first defined in this structured approach by Peter Hudson from Australia, and then they were translated into a long-term care setting from originally they were developed in critical care by Dr. Deborah Parker, who is also a co-investigator on this study. So through this structured approach, Sharon at the beginning talked about this, the use of the palliative performance scale, which triggers staff to recognize that a resident is moving from a cognitive and functional state to more towards a decline, towards end of life. So end of life could be anywhere from a year to 1 month away, and it's, as she mentioned, it's very complex to sort of prognosticate in this population. But using this 40% really did work quite effectively as an identifier to recognize those residents that were transitioning. However, after they were identified using the PPS, we still went to the staff to use their own clinical judgment to ask them which residents and families would then benefit from having a family care conference. So while 39 residents were identified as having PPS scores at 40%, only 24 actually went forward and had family care conferences, and some of them did die prior to that happening. But there ended up being some interesting findings between who the staff perceived as having a higher need for a family care conference, which I'll talk about a bit later. So they were organized and facilitated by a leader in the LTC, often by the social worker. So going to the next slide. So the mainstay of this intervention really is the use of family care conference forms. So while we actually had 6 documents in this intervention, the 2 main ones that are really the most useful are the resident family questionnaire and a plan of care conference summary. So the resident questionnaire, well, it either goes to the resident if capable or to the family member, is given to them prior to the family care conference. So they can write down questions, concerns, and it really gives them the opportunity to think about you know, sort of where their family member is headed and what their preferences would be prior to being in the meeting when, you know, they may be under some distress or some emotion. It also gives them the opportunity to rate a level of worry on a Likert scale from 1 to 10. And that was actually really interesting because a lot of staff sort of perceived that a family was really coping well and would have no issues at all, and that communication was excellent. And then they would rate their level of worry as a 10. So it was also, you know, quite enlightening for staff to realize that they don't always, you know, recognize when a family really is feeling anxious and concerned. So the plan of care conference summary is used during the conference by staff, usually by the facilitator, to guide the discussion and to document issues, goals, and planned interventions that come out of the conference. And these conference documents are organized according to palliative care domains, such as disease management, end of life, social care, practical issues. And by dividing them that way, it really promotes a holistic assessment so that none of the different domains are missed within the conversation because they're specifically on these forms. And these forms were provided in a paper format to the long-term care homes. However, some homes were already using electronic documentation and chose to just use their own means of documentation and not utilize the forms. Okay, and the next slide. So we collected 42 documents from 24 family care conferences, and then we did a content analysis using the different domains. These domains come from the Canadian Hospice Palliative Care Association Square of Care, and we identified whether they had been addressed within the conference or not addressed. And we're basing this just on the data that was on the forms or within the electronic charting, as well as we had researchers attend, I think, about 11 family care conferences, and so that kind of confirmed some of what we were seeing in the forms. So we can see that the strengths of the domains that were addressed were around physical issues and end-of-life care. So we're really pleased to see that because particularly the end-of-life care is kind of the primary goal of this conference. However, you can see down at the bottom of the chart that loss and grief were not discussed very often, and so that really gives us some insight into an area that needs to be tailored within the conferences. And it doesn't necessarily have to be a focus within the conferences, but just having bereavement material on hand, you know, offering referrals or resources to support groups prior to bereavement could also be really helpful for families, particularly because we know this is a really complex population that may be having anticipatory grief for quite some time. Family members have been caring for their loved ones for long periods of time through chronic illness, and so their grief experience may be different from others, and they may really benefit from more support within these conferences around that domain. Okay, so some of the family care conference benefits that we could see kind of overarching through the forms that were that relationships were being strengthened, communication was being strengthened, particularly between the families and the staff. They would often start the conference complaining about different issues and having a lot of concerns over their family members' hygiene or you know, misinterpretations of care that was being provided or not being provided, but almost all of the conferences always really seemed to end on a positive note. Everyone came away with having a clear direction and plan for the care of the resident, and families often expressed really feeling relieved and grateful. And as Tamara mentioned about these having to make decisions in the moment of crisis, this really provided the opportunity for decision making and care planning in advance of really, you know, significant changes where they were having to, you know, they were being pressured to put, you know, to put a plan in place or make a last minute decision. So just to describe a little bit of the decision making and care planning on the next slide, we just provided a few examples here of goals and planned interventions that were developed. And what I really wanted to highlight in looking at the goals is that, you know, a lot of people think about goals as just being sort of advance directive to, you know, resuscitate or not resuscitate, or go to the hospital or not go to the hospital. And while those goals are very important, through the palliative approach, the goals are really looking at optimizing comfort through any means and improving quality of life, all the way up until the point of death, and then for the family into bereavement. So you can really see in some of these goals that there's a combination still of active treatment here, as well as promoting sort of psychosocial quality of life, as well as symptom management. And I think often as clinicians, we sort of forget that, you know, goals can be quite broad and simple. And by reminding families of some small goals that are, you know, easily attainable and that are feasible, it also gives them hope for the future, because clearly their loved one is not going to live forever, but there are some things that we can plan and hope for that will bring everyone comfort. So some key findings. We were pleased that the majority of domains were addressed by the family care conferences. I think in general, about 5 out of the 8 domains were addressed consistently for each conference. Within each conference, about 2 goals were developed and 5 interventions were planned. One thing that's interesting in relation to those numbers is that one of our sites really consistently utilized the family care conference forms and also had the highest number of different disciplines attending from staff, including nurses, occupational therapists, chaplains, the social worker, recreational therapists. So a really wide, diverse number of staff. And at that site, we had higher number of domains that were covered per conference, as well as a higher number of goals and a higher number of interventions developed. So it really illustrated to us the power of that collaborative team approach and generating a really holistic, comprehensive care plan for the resident, as opposed to just focusing on the medical issues. We also looked just to compare which residents ended up having a family care conference versus those who did not. And we did see that those who had a conference, which was sort of organized using the PPS in addition to the staff's clinical judgment, those persons also by majority had a diagnosis of dementia. So to us, that sort of spoke to the fact that family members of people with dementia may have higher needs for communication and support at end of life as compared to family members of other residents. We also found that more goals were organized or were documented or recorded on the specific forms that we offered to sites as opposed to electronic documents, and the electronic documents did not have a specific category for end of life. So while we recognize that everyone is sort of moving towards electronic documentation in all settings, it would be really useful to translate these forms specifically into electronic format to ensure that goals, interventions, and all of the domains are adequately addressed in the care plan. And so for publication, the findings regarding family care conferences are currently in press in the Palliative and Supportive Care Journal. And now I'm going to turn it back over to Tamara. Thank you.
Okay, great. So remembering back to the slide that Sharon presented where we kind of had a model of what we thought we were going to implement, and remembering also that we were doing a PAR approach, one of the things that came up as we spoke to staff was we had an idea for activating advanced care planning, and that was putting in another care conference kind of more at the front end in the first 6 weeks of admission to start talking about what you might want and wish for at end of life. But staff felt that was not so feasible to implement given all the other demands. What they did want was an opportunity to offer family members and residents information about different illnesses that they tended of high prevalence in long-term care. And they thought maybe this would activate, by informing people of what could lie ahead, would activate also families and residents to start asking questions about kind of the next stage. So we developed 5 illness trajectory pamphlets, and again, we did not intend on developing these at the beginning. And what we did was we distributed them between March and August of 2016 in our 4 participating homes, either by wall display, when you walk into the home, they were just sort of all there, or target distribution if a staff felt that a family member or a resident would benefit from a pamphlet, they were given that pamphlet. And with the pamphlet, people were also given a survey that they could complete if they wanted to, around whether they used it or didn't use it or what their perceptions were. We also did some end of study focus groups with residents and families, just to sort of talk more broadly about what their perceptions and experiences with the pamphlets were. So we had 57 respondents from the surveys that we distributed, and we had 36 people participate in focus groups giving us feedback on the pamphlets. And I should mention the illnesses that were represented were advanced frailty, dementia, lung disease, heart disease, and kidney failure at end of life. So what we found in terms of feedback, that's the next slide, were people really did largely endorse the fact that the surveys encouraged reflection and that kind of helped direct people on what they might want to ask and sort of increase their comfort around talking. But it didn't actually activate the conversation. So it activated reflection, and people appreciated knowing, but it didn't necessarily as frequently activate people making that next move to talk with others about what they were worried about. And one of the barriers were that residents were worried about burdening their families and making them sad, and families were worried about burdening their residents. So moving kind of from reflecting to activation seemed to require some form of encouragement and follow-up, potentially by staff. So a common response was a resident would say something like, well, this is great, and I'm so happy you gave this to me, but I don't think my family would want to see this. And we would get the exact same kind of response from families. This is great, I'm so happy, but I don't think my family member would want to talk about this. So really interesting how one sort of tends to protect the other, which is likely a big barrier to moving forward with conversation. So we are kind of moving this along in another project and starting to look at using the pamphlets with a bit of staff support and how that might result in activation. So just also briefly to tell you about our knowledge trends, and we have collaborators, but we have many, but two that are working with us on dissemination: the Canadian Hospice Palliative Care Association and Canadian Virtual Hospice. They're displaying pamphlets or links to the pamphlets and conference posters on their websites, and they're also in October going to be launching some tweets and reposts on Facebook and Twitter. So we are trying to actively get the word out, in addition to, of course, continuing to put manuscripts together. We've got one under review right now in the Gerontologist. And largely, if you're looking for results from this study and products, you will find them with CHPCA or CVH. Next steps for us, as Sharon mentioned, we do have another funded project right now with CFN. The full team lead here is John Yu from McMaster. And what Sharon and I are leading is a project to activate advanced care planning and long-term care. So basically, it's taking that front-end conversation piece that we noted to be so missing in long-term care and seeing how we can encourage more conversation up front. The pamphlets were one initiative. Now we're looking at other workbooks that might be able to activate planning in advance, because that came up as a real need in long-term care. So stay tuned for that. It's a 3-year project. And if you would like any information today other than the discussion that we're going to have, we do have our contact information on the last slide. And as Sharon mentioned, we also have some project coordinators who I believe their contact information can be acquired through someone at CFN following the presentation. Thank you.
Yes, they will be available. We'll put their email up so that anybody who doesn't get their question answered today can email them directly. So thank you, Sharon, Tamara, and Pamela. Excellent presentation, very informative. And Perry will now start the Q&A. And please continue, everyone in the audience, to type in your questions so we can get to most of them. Okay, Perry.
Hi, everyone. Thanks again for your talk and walking us through your study. It's very interesting. We'll jump right into the questions since we only have 10 minutes. One of the questions we have is, wondering if metrics regarding death in acute and transfers to acute in the last 3 months of life were measured and evaluated to see results of interventions.
Okay, great question. And that's the data we didn't include on our slides. That figures that the pieces we miss are the parts that people ask questions about. We did do that. So when we talked earlier on about the different kinds of data that we collected, one of them was chart data. So we looked at ER transfers, hospital admissions, and hospital deaths within the last year previous to us implementing our SPA program. And then once we had, or it would have been a year later, we collected the exact same data over the previous year to see if there was any differences between the pre and the post chart data. So we didn't find any significant improvements, but we did see a general, improvement. So what I'm trying to say is we didn't have any statistical improvements, but we did see rates going from, for example, I think we had ER admissions around 64% in the previous year before we implemented, and they came down to about 61% after the intervention. So, and we did collect, so we looked at it within the last year, ER admissions, and we looked at ER admissions in the last month, and then the week before someone died. So we were just targeting those people who died and looking at ER admissions in the last year, month, and week of their life. So whoever's wanting that information, I would be happy to share that with you. If you wanted to send me a quick email, I can give you our exact results. But to be honest, most of our findings were consistent with CI-HI data for ER admissions and hospital deaths for long-term care residents. So there wasn't anything surprising, but thankfully we did see a general improvement in those rates over the course of the 2 years that we did the project.
Great, thank you for clarifying that. And presumably you'll be doing a similar analysis with your follow-on study?
Yes, we are. Yep.
Okay.
Tamara, did you want to speak to that?
Yeah, I think just to me, it sort of speaks to the fact that once again, we had this kind of gap in advanced conversations. The main intervention that we were able to implement over the couple of years was real end-of-life conversations, and they had a lot of value. But we're hoping that pushing these upstream conversations may actually change these results. So we're going to continue to track that into the next study, in addition to just general perceptions of feeling prepared, which we're also going to try capturing.
Right, thank you. This is a methodology question. In long-term care, why not use the CHEST score as a trigger?
Yeah, another great question. We had thought about using the CHEST score, but we decided to use the PPS for a couple of different reasons. It had been piloted in the London area for long-term care specifically and had not too bad of findings. And what we liked about the PPS is that we could use personal support workers to get them involved with completing the PPS. And it turned out to be more of a process piece, to be honest. So what we were seeing as we were moving ahead with the intervention is personal support workers felt more empowered, and they would go to the supervising RPN or RN and say, you know, I've noticed so-and-so is the PPS score has dropped to 30%. So it was a tool for them to communicate with the nurses, which was really nice to see. And we could get PPSs with the CHEST score and the MDS-RI data. It's generally collected every 3 months. That was probably one of the biggest barriers. But as we know, we can see significant decline over 3 months, and we really wanted to capture people in the moment. And the PPS was something quick we could do, you know, quickly. But we are looking at, again, with our next study that Tamara and I are moving into, we're partnering with John Hurdy's and George Heckman at the University of Waterloo and working on using some more inter-RI data instead of the PPS, or maybe with the PPS. So we will be looking either at the CHEST score, or I think John and George may have some different indicators that they're hoping to use.
Great, thank you. The next question is sort of an amalgamation of a number of questions we've had, but basically the gist is that maybe you could give us sort of some insight into the willingness of staff and physicians to engage in the study and participate in the study, and how difficult it was.
I can take this one. I think that that's really where the PAR piece came in. As much as we were studying outcomes, we were also studying and contributing to process. So our champion team that we developed, which was sort of a team of leaders to provide us with consultation throughout the course of the project, came from the focus groups. We did these focus groups. People started to get interested. They volunteered. They said, oh, maybe I want to work with you. And then we kept people informed by having monthly champion meetings and also comfort care rounds, which were educational opportunities for staff to talk together. So what you saw was these light bulb transition moments when somebody learned all of a sudden changed their practice. They got very excited and more engaged. And that really happened only because we gave staff so many opportunities to get involved and provide feedback throughout the course of the project. And also I think it helped that they saw us produce things that they wanted. So the illness trajectory pamphlets was their initiative, and they were very excited that they got heard and we did something that they had asked for. So I think that it's really the PAR approach that supported the engagement. And, you know, now that we're back, we're in the same 4 long-term care homes. This is now 2 years post our initial work. Everybody was excited that we were back to do this next project. So it really, the process, I think, is a really useful process for engagement in long-term care.
That's great to hear. If I could just ask a follow-on question to that. I was curious in terms of the residents and families, how willing were many of them to sort of engage in palliative care approaches? I know in some situations people don't want to consider considering palliative care versus other care methods. Is that any different in the long-term care?
Well, I think, again, it came to the education. When palliative care, what needed to happen was palliative care needed to be reframed as not just end of life, but planning ahead as a larger sort of principle. And we had a lot of people, you know, we put that definition in our pamphlets, and we use that definition when we invite people to the family care conferences. And what we find is people say, gee, wow, I thought palliative care meant I'm going to die next week. And so it kind of shifted people's receptivity. It's a lot easier to plan ahead for something that, a situation that you don't feel you're in now. And I think probably Pam can speak to how that then played out in the end of life conferences. But I think that there too, when you had interdisciplinary support and your questions were being answered, this shifted people really nicely into starting to be able to process decisions that made sense for them.
I just wanted to add a little bit as well to what Tamara was saying. There was, and it was a specific example actually at one of our homes. About 3 months into the project, you know, we had probably about 3 or 4 champion team meetings. I came to a champion team meeting, and a couple of the residents came to it as well, and they had been working on what's called a dignity blanket. So this was something really that kind of, it was very organic within this home. It wasn't something that we were, you know, telling them to do, but it was almost like the project and the, you know, the whole discussion around this palliative care program empowered residents to kind of take some initiative on their own. So what happened was there was a group of residents, I think about 10 of them, who were meeting regularly with a rec therapist, and they decided together they wanted to make a dignity quilt. So they used our logo, which you probably saw it on the some of the slides, which was a tree with these multicolored hands on the tree. So they essentially replicated that logo and made it dignity quilts. And it took them, I think, about 3 months. They traced their own hands, and they painted the hands in the same colors as the logo. And they used that quilt for residents. Once they passed away, they would put the quilt over the body and take them out the front door. So it was quite a, you know, I think I mean, this kind of thing we're seeing a lot more happening in long-term care, but for me, it really showed that residents were feeling empowered, the staff were maybe more empowered to talk to them, and they took it upon themselves with this, you know, rec therapist to make this quilt. So kind of neat to see that.
Wow, thank you. That is great. I love that story, a dignity quilt. I think it's great. Unfortunately, I think we're running out of time today. I see people having to get off right now. So again, thank you so much for your presentation and sharing some of these great stories that go along with your research. And I can see why they understood that you weren't part of the research team. And I hope that everyone can join us for our next webinar on October 11th. And I guess that ends today's webinar, and hope everyone has a great day. So thank you for joining us today.